Alright, it's cardiovascular pathology. It's Tuesday, it's week 10, winter 2021. Yes, this is a big lecture today. Wolff-Parkinson-White Syndrome, AVRT. We're going through orthodromic and antidromic and myocardial infarction. Probably the biggest lecture I think I've done this quarter, so it's a very important one, very juicy one. Right, Wolff-Parkinson-White syndrome. We've been talking about it a little bit, but let's dig into it officially. So these patients are going to have a hole in their fibrous skeleton that allows the atria and the ventricles to talk together electrically. Remember, normally the current started in the SA node, sweeps over the atria, passes through the fibrous skeleton at a spot where the bundle of His pokes a hole through it so it can connect to the AV node. That's the only hole there's supposed to be. But some people are born with an extra hole. If they have an extra hole in the fibrous skeleton, and if it has super fast conducting fibers within the hole, I mean, maybe the hole is just plugged with scar tissue, that's no big deal at all. But if it has these super fast bundles of connective tissue that conduct current super fast, they're called Kent fibers or Kent bundles. Then they have Wolff-Parkinson-White syndrome. And that hole plus the Kent fibers, if you have both of those, you're said to have an accessory conduction pathway. Right? So we've looked at this before. So there's a hole in the right atria where the right atrial ventricle can communicate through this green bundle of fibers, and those are called Kent fibers. So this patient has Wolff-Parkinson-White syndrome. So how does the current flow in a heart that has this setup? Let's look at it. You can read about it. So the SA node sparks an action potential. Remember, we have Bachmann's bundle here. Remember, if you went through my lecture on that, it's super fast highway, right? It's almost like having an SA node over here as well. And so all this wave of depolarization is heading toward the AV node right here. But we have one of the intraatrial conductive pathways in this example is very close to this hole with Kent fibers. And so therefore some of the current can sneak right on down through this hole, and there's no slowdown mechanism here. It jumps right in. And so this part of the ventricle is depolarized. Before this, I mean, this one is still hung up in the slowdown portion of the AV node, right? The AV node grabs the current and it slows it down here. So we get a premature ventricular depolarization with this setup. But the current can't spread very fast because there's no Purkinje system. There's no bundle branches. There's nothing for it to speed through. So it moves like a turtle. And I mean, a turtle is still could be 250 beats per minute, but it's not 500 beats per minute. But it goes slow. So while this one's putting along, this one finally, the normal, we'll call this the SA current. The SA current, we'll call this one. It's the SA current, we'll call this one the WP, Wolff-Parkinson-White current here. So finally, once the SA current gets into the bundle of His, it just flies down the bundle branches, flies around the Purkinje system. All this side of the heart contracts completely normally. The only part that doesn't contracts strangely is right here, and electrically it messes up the EKG. But what happens is these two currents collide. I can make that yellow, can't I? These two currents collide right here. And there's a collision, and they both get snuffed out. So that's the end of them. This area doesn't matter because this area is already depolarized, and this area will contract and depolarize normally. So normally they have a little hiccup in their heart. They have a little collision here, and that's what Wolff-Parkinson-White syndrome is. Right? That is an important word. Ventricular pre-excitement means that part of the ventricle contracted before it was supposed to. And that happens. People with Wolff-Parkinson-White syndrome have ventricular pre-excitement. Got it? All right, and yeah, and we went through this already. Normally the two currents, the Wolff-Parkinson-White current and the SA node current, they collide. And they collide a short distance from the Kent fibers. And everything I just said, I explained that already. What effect does the collision have? Usually none. Perhaps some people who are really sensitive, they might experience palpitations from the collision. Some people theorize, but usually nothing. It's no big deal. Right, there's this that thing. There's the collision again, and yep, I explained that already. All right, so now what are the EKG findings going to look like in someone with Wolff-Parkinson-White syndrome? Well, they're going to have a ventricular pre-excitation. So remember the normal. Let's see. Remember the normal. Let's draw the isoelectric line. Let's see, what color haven't I used for a while? How about green? Remember the normal. We have a P wave, a PR segment. That's a terrible color, isn't it? P wave, PR segment. May or may not have a Q wave, R wave. This is way too big. S wave, T wave. Right, so that's the normal type setup. So this part right there, the PR segment, that is where the current is getting slowed down in the AV node. That's that's where decremental conduction is occurring. So if we have current sneaking in ahead of time, this is going to be gone, because EKG doesn't know where the depolarization occurs. All it cares is that this part of the ventricles are depolarizing somewhere, and so you get this big hump right here. Right, so you get a short or non-existent PR segment in someone with, and therefore you get a short PR interval as well. This will also make the QRS complex way too wide because of this premature depolarization of the ventricles. Got it? So this is called a delta wave, this kind of slurring. I'm exaggerating just so you can see it, but that's called a delta wave. And yep, you get a wide QRS complex, will be greater than 2.5 millimeters. JR interval is going to be short, no PR segment. The RR intervals will be normal. There's a normal rhythm of this heart. Right, so here's a better drawing than I just did, but you can see normally we have a PR segment right here, and there's a Q wave, but if the ventricles prematurely contract because current has snuck through the Kent fibers, you lose that. And you get this scenario right here, and this is called a delta wave. And remember, this R wave should be built with straight lines. And this breaks the straight line rule. That's not a straight line. See how that works? All right, 44-year-old comes in your office after a bike race with some anxiety, weird feeling in her chest. His heart was racing for 30 minutes after the race, but finally slowed down a little bit by the time she got to the tent. So what do you think? Our intervals look good. What's the speed? 300, 150. Yeah, it's a little under 100, okay? So it's not even a tachycardia. PR segment, PR interval, 3x5 note card. It shouldn't be, it should be at least 3. So there's 1, 2, 3. It's like barely 3. How about the QRS complex should not be more than 2.5. That's where we're going to, something's wrong. I can see already. Let's measure it right there. So it should not be more than 2.5. There's 1. There's 2. There's 0.5. So we're past 2.5. We're about 3 on this one. So this one's a little tricky, but is this made with a straight ledge right here? Nope. There's a little slur right there. Right, there's another one. This is made by two lines. Right, so that's a delta wave. So this is a patient with Wolff-Parkinson-White syndrome. Okay, there's normal. You can see one straight line. It's off a little bit, but one straight line. And you can see this is slurred right here. It's not a straight line, it's a curved line. And there's no PR interval, or there's no PR segment here. So this is Wolff-Parkinson-White syndrome. Got it? Everything I said. Yep. So what happened is they probably went, we'll learn in a minute that people with Wolff-Parkinson-White syndrome, they are prone to develop a tachycardia, fast racing heart, called atrioventricular reentrant tachycardia, or AVRT. And so what happened is she probably had a run of, she probably went into AVRT, and then it went back to normal sinus rhythm, but it just scared her. So we should talk about AVRT. It's the second most common cause of supraventricular tachycardia. It's when it's present, when you see this in your office or you see it wherever, if you're in the emergency room, it's the second most. It's about 80% of the time it's seen in someone with Wolff-Parkinson-White syndrome. Not always, though. People with Langerhans-Levin syndrome can also have AVRT. It can occur in any time there is one of these bypass tracks. Anywhere you can set up a loop of racing current, it can occur. What's the cause of it? Well, this is why we talked about ectopic foci, because it started by an ectopic foci. It's got to be a perfectly placed and perfectly positioned ectopic foci. And this ectopic foci will hit one of the currents, either the WPW current or the SA current, and it knocks it out, and those two collide. And if that happens, then there's nobody to collide with the other current coming through. And that current can go right back up into the atria, go back through the AV node, and set up a racetrack. And let's go to the picture, because some of you are probably scratching your heads on that one, and it's complicated. But this racing current is called a reentry circuit, and we've talked about micro reentry circuits, and it's the same kind of deal. So let's look at this as the most common example right here. So we've already explained this. So we have two currents. We have an WPW current has got in here. Normally it collides right about here with the SA node current, as I've explained before. But what's happened this time, before the SA node current gets here, a perfectly placed ectopic foci occurs right there in the ventricle. And the WPW current collides with the PVC, and the two are vaporized and are gone. And if this tissue is fast enough repolarizing tissue, here comes the SA node current and can just keep going right up backwards through the Kent fibers. And when they come out here, this is like an SA node. A new action potential has sparked right kind of at the mouth of the Kent fibers. Some of the current goes right back down the AV node and acts just like a normal current. The AV node doesn't know where it came from. Some of the current goes and hits the counting down SA node and knocks it out. So it can't release another current because it keeps getting hit. And then this current gets held up as usual, and then it's released. And then it goes around again. I mean, it could go both ways. There's the moderator branch I didn't draw. But this time there's no SA node current coming, right? Because the SA node got knocked out of action. So we don't have anybody to collide with. So it comes back up, does the same thing, goes back up, knocks the SA node out again, goes around, comes back up. Part of it knocks out the SA node. The SA node keeps trying to depolarize and make a new action potential, but it keeps getting hit by this circle. And it goes around and around and around and around. And that is classic AVRT, atrioventricular reentrant tachycardia. Very common cause of a racing heart, especially in people with Wolff-Parkinson-White syndrome. Got it? All right. There's two types of AVRT. The one I just described to you, that's orthodromic. Orthodromic AVRT is the most common. It's not very deadly. It's not that big of a deal. It's very uncomfortable though. But that's the one I just described. And it goes through the AV node normally in a retrograde manner. Is that the right word for that? Retrograde. Yeah, retrograde. It goes normally, the normal direction. Antidromic AVRT is dangerous. That occurs when this whole racing current goes the other way. So instead of and I'll show you a picture of it in a second, but instead of the WPWP current getting snuffed out, it's actually the SA node current gets snuffed out by a premature complex. And the WPW current races around backwards in a big circuit, big macro reentry type circuit. And that's very dangerous because if you run backwards through the AV node, the slowdown portion doesn't work. You fly right through there like nothing. And this is a very dangerous. It can run really fast because it's not getting slowed down. All right, that's called antidromic. So again, let's look at the picture of this. So in the SA node, it sparks an impulse, and it goes over here. It didn't draw everything, but it's headed back this way. But this middle interatrial nodal pathway is usually the one that hits the AV node. It got hit with a premature atrial contraction, and these two cancel each other out. Right? So there's enough delay here, because normally this gets in, it's held up, and the collision occurs right here. But it doesn't. We have to wait for some of these to come over and get in. These can't get in because they're going down the Kent fibers, becoming the WPW current. And so we have no collision. So these guys get into the Purkinje system, and they can go pretty quick. And they can come out the end here and beat these other atrial impulses to the AV node. And some of them go right back down the Kent fibers. Some of them go up here and knock out the SA node. Some of them go over here and collide with that current coming around. And once all these currents are taken out, the next circuit is really easy because there's nobody to collide with at all. It comes out here. Some of it hits the SA node, knocks it out. And some of it goes down here. So you get this big macro reentry circuit. And it goes incredibly fast, sometimes over 200. And these are the ventricles running over 200 beats per minute. Why? Because we're going backwards through the AV node, and there's nothing to slow things down. Do you got it? Do you understand? Okay. Fun facts. At some point if you're born with Wolff-Parkinson-White syndrome, and this is congenital, you're born with this, about 50% of WPW patients will develop AVRT at some point, at least once in their life. The bad thing about it, in and of itself, it's an uncomfortable rhythm, the orthodromic AVRT, but it can, 20% of people with AVRT, that AVRT can worsen into atrial fibrillation. Right. AVRT can occur, we already said, along other conduction pathways as well, like Langerhans-Levin syndrome can happen. Orthodromic AVRT, the AV node saves the day, we already said that, but there it is in print. The AV node is still working in orthodromic, and it slows down the rate of ventricular contractions. It's not going to run super fast, but it's still very uncomfortable. Your ventricles can run 180 beats per minute, and that's very uncomfortable. You will go to the ER to get that, to have that stopped. What are the EKG findings in AVRT? The ventricles are running fast. Remember we said they're similar to junctional tachycardia. They're really hard to tell apart sometimes. But the junctional tachycardia is slow, typically slower, like 120, 130 beats per minute, where AVRT runs 180 beats per minute. Sometimes it's even hard to tell about from AV-NRT, which we're not going to have time to get to. But yeah, those three always should be differential diagnoses for one another. The P waves, just like a junctional tachycardia, the P waves are way late, often really late after the QRS complex. They might even be in the T wave, they're so late. And now junctional tachycardia can do that as well. But they're not always late. Sometimes they can be in the S wave and they can cause a slurring of the S wave just like junctional tachycardia can. So it's really hard to tell these two apart. And even AV-NRT can cause a slurring. So the P wave morphology, is it up or is it down? Junctional tachycardia will always be down. So right is upright, just like with PACs, premature atrial complexes. If they're in the right atria, they're upright. Same deal here. If they start in the right atria, they will be upright. So that's another difference you can tell from a junctional tachycardia if they're upright. There will be no delta wave. I always ask this question for those of you who are actually listening to this. There is no delta wave, and people think, well, wait a minute, Wolff-Parkinson-White syndrome, they have a delta wave. Yeah, they have a delta wave when they're in normal sinus rhythm, but not when they're in a funk, not when they're in this AVRT, because there is no SA node, right? It's not a sinus rhythm, so there will be no delta wave. QRS complexes are typically normal. Yep, unless the P wave slurs the S wave, as we'll see here in a minute. Orthodromic AVRT versus junctional tachycardia. As I said, it's hard to tell them apart, but the junctional tachycardia is slower than the orthodromic AVRT is faster. The T waves typically occur later in AVRT compared to junctional tachycardia, and sometimes did I say T waves? The P waves of AVRT are typically much later in AVRT compared to junctional tachycardia, all the way near the T wave. But sometimes the P wave could be upright we said that already. It could be upright, and that will never occur with junctional tachycardia. Right, here's another orthodromic AVRT. So you can see there's no P wave here, or there's a P wave. Or no, that's the T wave, right? No P wave. The P wave is way late in this patient with orthodromic AVRT. And there it's way, way, way late. It's not slurring anything in this case. Okay, the 55-year-old comes in, pre-employment physical, so she's very healthy. You run an EKG to see if her heart is healthy looking. What do you think of this? It's kind of hard to see. Did I blow it up a little? But to me, that R wave looks a little slurred to me. I don't see a P wave. Do you see a P wave? I see a nice T wave. I see no P wave. So it could be it's definitely a tachycardia. How fast is it? That would be 300 beats per minute. That would be 150. This one's going pretty fast, probably 170, 180 beats per minute. So this is looking like AVRT to me. And yeah, it's going 188 beats per minute if you use the 1500 millimeter little box rule. And yeah, differentials have to be AV-NRT and junctional tachycardia as well. But that's pretty classic. There is no delta wave. What am I talking about? Because the delta wave is not, you only see that in sinus rhythm. So that's just kind of an artifact there. But is it? It shouldn't be more than 2.5. 2.5. No, it's not. It's less than 2.5. I thought for a minute it might be a little long, but it's not. Right? AVRT. Okay, what's the treatment? Same as for atrial fib. And the other tachycardias, try vagal maneuvers first. If that doesn't work, you go to adenosine. If that doesn't work, cardioversion. And once you get it stopped, they probably will have to go on to some maintenance therapy like metoprolol to hopefully stop it from coming back. The dreaded, yes, we've talked about this dreaded antidromic AVRT. Again, very dangerous. I already talked about it. Macro reentry circuit. The heart runs really fast. You can get myocardial ischemia. It can kick off a full-blown myocardial infarction, and you can die from that. And it occurs when the SA node generated current gets knocked out by an ectopic foci, probably in the atria, but it could be in the junctional region, could knock it out coming through the bundle of His or coming through the AV node itself. But the key is the SA node generated current gets knocked out. The Wolff-Parkinson-White rebel current, if you will, runs unopposed backwards through the AV node. It's not slowed down if it goes backwards. And now you get yourself a bad problem. And there's that same example we already said about this, and you can see the current racing, and there's nobody to stop it. Why is this dangerous? The AV node doesn't stop it, and the ventricles can run incredibly fast, typically above 200, sometimes even to 300, and you can't live long like that. So this is not a good one to have. EKG findings, this is the first one we've seen where we're going to have a wide complex tachycardia, and it's going to be much bigger than 2.5 millimeters. And yeah, so let's take a look at it. Oh, not yet. So you get this wide QRS complex. We're still talking about EKG findings. Why is it wide? Because of the backwards slow cell-to-cell spread through the heart, because the current is running backwards through the Purkinje system, even though it's not that slow, right? If it's running 300 beats, but it's not running 500 beats per minute, which theoretically you could run current that fast through. Like in atrial fibrillation, we know they atrial fibrillate at 550 beats per minute. P wave is not as late, but it still can be late. This is the one that more likely will notch the S wave. So AVRT can, but the way to remember AVRT, it's usually a really, really late P wave in orthodromic. Antidromic will be late, but usually not that late, and this is the one that can notch the QRS complex. Right? So 45-year-old comes into your tent after marathon complaining of dyspnea and is in obvious distress. He is somewhat cyanotic. What do you think? Well, let's look. Our intervals look good. What's the speed of this heart? Let's see. This one's right on one of the major hash marks. Whoa, that's 300. It's just under 300 beats per minute. This heart is really, really flying dangerously fast. So let's see if we can figure this out. There's the S wave, or there's the R wave. There's the S wave, and look how wide it is. It's way bigger than 2.5 little boxes. So this is a wide complex tachycardia. And if you look closely, you can see a notch right here. There's another one right there. You can't see them on every one of these. But there's one right there. That is actually the P wave notched in the S wave. And so this is dangerous. You call the ambulance over, you ever see something like this. Right? That's no good. That's antidromic AVRT. And his big box rule, if you do the math, it comes out to about 235. So that heart is really, really, really flying. And notice that notched P wave, as we said already. Okay, remember that. I guarantee that'll be on the test. Remember that. That's a deadly one. Final warning about antidromic AVRT. You have to be careful with vagal maneuvers and pharmacological conversions, so adenosine. They'll have no effect on this because those treatments affect the AV node. And in fact, pharmacological cardioversion like adenosine and the vagal maneuvers will actually make the heart rate faster, so you could even kill the patient by doing these. So you have to be able to recognize this wide complex tachycardia. Don't send them to the ER. Don't mess with that thing. Don't try any vagal maneuvers on that person. You could kill them by that. Cardioversion is the only option in these cases. Whew, okay. Last topic, myocardial infarction. Finally got this. I haven't put this in for a couple quarters. I've been thinning things out so I could get this important lecture in. Myocardial infarction is a heart attack. It occurs when cardiac muscle experiences severe ischemia. It's not getting enough oxygen and it's starting to die. And it will let you know because it has nociceptors in it, and it will send signals to your brain, and you'll have incredible strong pain in your chest. And depending on if it's a full-blown myocardial infarction, you will have, it's classically described as an elephant. I feel like an elephant is just crushing my chest. It's a suffocating type pain. Yep. So it's usually caused by atherosclerosis of the coronary arteries. So you get clogged up pipes and your heart can't get enough blood because the pipes are clogged. There are other causes of myocardial ischemia other than the clogged up pipes from atherosclerosis. People with really, really low blood pressure may not have enough force going through the coronary vessels. So that causes ischemia. If your heart is beating really, really fast, like in ventricular flutter or ventricular fibrillation, that's no good. If it beats that fast, you're not getting the coronary arteries to fill enough, and it can cause tissue injury. And then you can have a spasm of the coronary arteries from, like Raynaud's phenomenon, where you get the tunica media goes into spasm, it narrows the lumen. What's some epidemiology of this? Every 40 seconds, someone in the United States has a myocardial infarction. Every 40 seconds. That's about almost 800,000 Americans have a myocardial infarction each year. Most of the time, it's the first heart attack. But sometimes it's the second time they've had a heart attack. Those are the breakdown numbers. And of course, I don't want you to memorize those numbers. 20% of these myocardial infarctions are silent. That's a number you should probably know. It's an easy one to remember, 1/5 of the time. What does that mean, silent myocardial infarction? That means they have no pain. They maybe get dizzy or something, but they don't have any chest pain. You don't always have to have chest pain. What are some of the risk factors for myocardial infarction? Eating this every day for lunch, which looks delicious. Pre-existing atherosclerosis, which from faulty LDL receptors, we've talked about that. Having a really bad diet where you're eating food like that, bacon and red meat and pizza, lots of cheese and fat. And then just getting old. Those all increase the chance of having a myocardial infarction. Just to know about Robbins, they say that myocardial infarction falls under the heading of ischemic heart disease. You Google that term or go PubMed that term. It's not. I don't know where they got that. I don't know if they're making that up themselves or where that came from. But watch out for that word. It's its own category. Which arteries can get clogged? Well, any of the coronary arteries, but the more dangerous ones, the left coronary artery, the left anterior descending artery, the left circumflex artery, right coronary artery, they can all get clogged up, and you're in big trouble if they do. Let's remember these arteries here. So this is the left coronary artery. This is the right coronary artery. Circles all the way around the back. Right? Normally the right coronary artery takes a turn right here and becomes the posterior descending. I think you guys learned it as the posterior interventricular artery. No one really calls it that in clinical cardiology. It's always the posterior descending. And the left coronary artery is very short-lived. It splits into the very important LAD. You guys called it the anterior interventricular. It's the left anterior descending. Notice these anastomoses here. Posterior descending anastomosis with the left anterior descending here. And then the other branch is the circumflex. Some call this the left circumflex. It goes around the back of the heart and in a right-handed coronary artery system. It kind of peters out here. It doesn't. In a left-handed system, this makes the posterior descending, and the right coronary artery is the one that peters out. Right? Yep. So those are the big players. How does atherosclerosis cause ischemia? Well, it's a beaver dam, right? Give me a second here. I got it in my little chair here. I need to change positions. Hang on a second. Okay, still moving around here. Guess we're taking a little water break too. All right. All right, so how does atherosclerosis cause ischemia? Well, what do you mean? How does atherosclerosis cause ischemia? Well, that's a beaver dam, right? The lumen gets all clogged up. There's an artery. And if you have all gunk inside the vessel wall, there's your lumen. So you don't get much blood flow, right? So that's luminal narrowing. It's usually from atherosclerotic plaque or atheroma buildup. And heart attack happens when the atheroma rips open. Remember we talked about breaching? That's a really important concept, breaching. Number one cause of myocardial infarction is a atheroma that ruptures. That's called breaching. What do you make of this? 48-year-old male comes into the ER with diaphoresis, chest pain, and dyspnea. What's diaphoresis? That's sweating. They're sweating. People with heart attacks, they sweat. It's a classic sign. Board question. Chest pain, out of breath. You run an angiogram. What do you see? Here's the left coronary artery. Remember I said left is very short-lived. It splits in two pieces. Splits into the LAD. There's the left anterior descending. And the circumflex. The left circumflex is here. Whoa, we got a big fill defect, right? So we got, this would be plaque. This is solid plaque formation here. And I bet a piece of that plaque broke loose and it went down and it's beaver dammed right here. Because we should see a continuation of that artery. The filling with contrast, but it doesn't. So that's no good. We also have some pretty bad plaque right here in the LAD as well. But that's a complete blockage there. So that's a heart attack. All this muscle is dead. It's a heart attack. Everything I said. How do you make the diagnosis of a myocardial infarction? There's 4 components. There's the history is very important. Physical examination. Blood work. Looking for troponins, enzymes, and EKG. All right, history and exam findings. So it's classically feels like the patient will tell you, maybe they have a history of hypercholesterolism or hyperlipidemia. But they'll say, God, it felt like somebody was squishing my chest, or maybe it still does. Just the patient saying, I can't breathe, feels like somebody's suffocating me. I can't. It's like somebody's sitting on my chest. Where the pain radiates, it may be right in the heart, but it classically radiates down the left arm, or in the left shoulder, in the jaw, or in the throat. Nausea, diaphoresis is classic, we said. They're going to be sweaty when they come in, part from anxiety, I think. Sympathetics are turned on. And dyspnea, they're having trouble breathing. And let's see. Now, watch out for people who are diabetic and the elderly. Sometimes their nerves don't work very good, and they can't feel as much pain as normal people, especially diabetics. So 33% of diabetics in older people, like I'm talking over 70, they don't have a clear picture in these people. So you have to be careful with them. They can't feel the pain very good. And also, some of these symptoms of chest pain and arm pain and throat pain, GERD can do that, and peptic ulcer disease and pulmonary embolism, some of the esophageal disorders. We need to talk about angina pectoris. There's 2 types of it actually. But these are chest pains. They're like mini heart attacks. They're like little TIAs, trans ischemic attack, which is a pre-stroke. And these can produce discomfort or real pain. Real pain it's a pre-heart attack. Discomfort is not quite as alarming, but it's on your way to a heart attack. They can be brought on by exertion, walking up the stairs, or getting in a fight with somebody, any emotional stress, or they can be paroxysmal, meaning they occur out of the blue for no reason. They're caused by transient bouts of myocardial ischemia, these attacks. So they're like mini heart attacks. So maybe part of the heart, maybe the thrombus, a little piece of thrombus has broke and caused a little embolism and it's got stuck somewhere. Or maybe it's just you have only 5% of your left anterior descending artery open, and you just walked up the stairs and your heart can't pump enough blood to feed itself. The heart is busy perfusing the body and pumping hard, but it has to perfuse itself, and it can't. So these are like pre-heart attacks. And they can cause these little angina attacks can cause severe ischemia. It can kill the heart slowly, and it can result in cardiomyopathy, ischemic cardiomyopathy. What transmits the pain anyway? There's no somatic nerves to the heart. No, but the parasympathetics and the vagus, the nerve, and the sympathetics, they have afferent fibers that can transmit pain. It doesn't do a very good job of it. The brain gets confused sometimes on where it's coming from. But yeah, that's called a visceral pain. So heart attack pain is a visceral pain. Specifically, it comes from T1 to T4 and T7 to T9 if you want to really get into the weeds. So there's actually 2 types of angina. There's a stable angina, which is the most common form. And the lumen of the coronary artery must be closed by at least 75% or more. Or the lumen must be decreased, by at least 75% or more. And the heart can't handle the oxygen demands of myocardium. If you walk up the stairs and your heart has to pump harder to feed the body more oxygen, it can do that, but it can't feed itself because the pipes are clogged. All right, so you get, that's called stable angina. And it's not described really as a pain so much. It's more of a discomfort. It's not a flat out pain. It's not going to send you to the ER. It's just you think, do I have GERD or what the heck is this? It's not comfortable, but it's not excruciating pain. And what can set it off? Emotional distress, exercise, physical stress, psychological stress. Excessive heat could do it. The symptoms, again, the brain isn't good at feeling where the pain is, so it could be referred to any of those places we talked about, down the arm, to the jaw, to the throat. And sometimes the patient can't put a finger out. The pain feels vague and jumping around. It's kind of not a real precise. It's poorly localized. But it can be a squeezing type of pain as well, but not like the elephant on the chest. Some people get a burning pain, so it's mixed up with GERD. The key with stable angina, though, it goes, your attack is only 20 minutes long and then it's gone. And the pain is not said to be it's more of a discomfort. It's not going to drive you to the emergency room like unstable angina is. Where does it refer, these pains refer to? The precordial region, the T1 dermatome of the left arm, if you want to get specific. So that would be the medial arm, the medial arm. Maybe a little overlap with the forearm. The cervical spine, posterior or anterior cervical spine, the esophagus, the mandible, and the epigastric region. Now, stable angina treatment. Usually if you just rest, it goes away within 20 minutes. You might need, if you're anxious about it, some people kicks off an anxiety attack when they get this pain, so you might need Valium. Vasodilators might be needed if that doesn't work. So these are people popping nitroglycerins or nitrostat, and those are vasodilators. They'll open up if the coronary artery is closed by 75%, and you take a nitrostat, it'll widen it so there's only a 50% block. Now, unstable angina is no good. This is pre-heart attack pain. Sometimes it's called crescendo angina, non-exertional angina. It's a real chest pain that it'll go for greater than 20 minutes, greater than 30 minutes. It's pre-heart attack pain. You get to the hospital immediately if you have a pain like an elephant standing on your chest. Classically described as an elephant sitting on the chest. May come out of the blue, could come on with exertion. What is it caused by? There's been studies done on this, and usually what happens is that artery that's 95% occluded with atherosclerotic plaquing, the plaque rips open. Remember, we've talked about that. That's breaching. Breaching occurs, and a blood clot will form immediately once blood is exposed to the innards of the artery wall where the inflammatory atherosclerotic process is going on. Breaching will occur, and you'll get a complete clog within minutes. Either that or that breach part and that clot that's forming will break loose and go downstream and get caught in a smaller artery. So you could have a coronary artery embolism. Sudden cardiac death syndrome. So sudden cardiac death syndrome, this breaching, and you have when you have breaching and you have severe myocardial ischemia, so part of the heart is dead. The part that is in ischemia and dying gets really cranky and twitchy, and it could spark a ventricular tachycardia, or maybe something a little slower or faster like a ventricular flutter, or even faster like a ventricular fibrillation. These are no good. We don't have time to go over all of these, but they're no good. They can kill you when ventricles go into flutter or fibrillation. And heart attack, dying in ischemic tissue, gets really cranky and it prones to beat the SA node to the punch and can run the ventricles really fast, and it can kill you. And that's sudden cardiac death syndrome. If someone has a myocardial infarction, a piece of heart dies and gets cranky and triggers a ventricular tachycardia. Okay. Non-atherosclerotic MRI, yeah, so about 10% of even the giant myocardial infarctions, the pathologist goes in there on autopsy and there's no sign of atherosclerosis. So you can get these non-atherosclerotic myocardial infarctions. So what's the deal with that? What is a transmural myocardial infarction? That means the ischemic, the dead heart tissue, includes the myocardium, endocardium, and pericardium. It's a full thickness injury. What are the causes of this? And it has to be non-atherosclerotic, but vasospasm. Coronary arteries have a good tunica media. If that goes into spasm, it can pinch off your coronary artery and you get downstream ischemia. Cocaine, ephedrine, too much of that can cause this. Idiopathic coronary artery vasospasm could be. It's like Raynaud's phenomenon of the heart. I think I cut those slides out because I just don't have enough time. But embolus from somewhere upstream, like the atria. We've talked about how atrial fibrillation can throw an embolism. It doesn't always have to go up to the brain. It could roll down in the coronary artery, right or left coronary artery, and get stuck. Get stuck in the left. Did I tell you this? What happens if it gets stuck in the LAD, the left anterior descending? That's called the widowmaker. That's a really bad deal, right? Those cause widowmaker because those often kill you. But yeah, so you could get an embolus from infective endocarditis. Maybe it's the left ventricle itself has a bug ball growing and it breaks loose and goes in the coronary artery. Paradoxical embolism, going through someone with Eisenmenger syndrome. And yeah, coronary artery atherosclerosis could develop. Well, we talked about that, right? When breaching occurs, a piece of the clot can break loose and go downstream. So those are all embolisms causing a beaver dam, causing downstream ischemia. And vasculitis could do it. You could get an inflammation of the smaller intramural coronary vessels. Early diagnosis is the key to saving someone's life. The old cardiologist would say, time is myocardium, and it's true. So even severely ischemic cardiac tissue can be revived, at least partially, or reperfusion, that's called, to kind of bring it back to life, to get it oxygenated and working again. As long as 25 minutes hasn't gone by. 25 minutes is kind of a magic number. Reperfusion, so there's several techniques that are reperfusions, certain medications, and a reperfusion is any technique that restores blood flow to the ischemic myocardium. So medication, thrombolysis, angioplasty, stent placement, coronary bypass are all examples of reperfusion treatment. How do you make the diagnosis of a myocardial infarction? Well, classically, the patient has that crushing, stabbing elephant on the chest pain. It goes on for more than 20, even more than 30 minutes. It's a pretty good indication of a myocardial infarction. Diaphoresis, they're sweating like crazy. They're vomiting, they're nauseated. They have dyspnea. So those are the big signs there. By the way, the nausea and vomiting often mean that it's a posterior inferior ventricular wall that's developed the infarct. EKG findings of a heart attack. We've talked about them way back when we talked about pericarditis. But ST segment is elevated. The Q wave gets huge. Remember, the Q wave should only fit in one small little box if it's present. It can get really, really big. I took a lot of slides out of here because we just don't have time. But here's a 66-year-old who comes in with chest pain, diaphoresis, into your tent after a marathon. 20 minutes after, he's just not feeling good. You run an EKG, what do you think? Oh, wow, we got a bunch going on here. You guys see it? Well, let's look at limb lead 3. First of all, what's that squiggly line? Good, somebody caught it. There it is up there too. What is that? Good, it's AFib. It's atrial fibrillation. All right, but look at here's the R wave, the up limb. There's the down limb. Whoa, it's supposed to come way back down here. There's the start of the S wave. Right? So that's elevated. So that's ST segment elevation. Okay, there's just a close-up of it. Yeah, there's a bundle branch block in there as well, but we don't have to worry about that. I don't have time to. Never enough time in this class. Another example. This one you can tell. I took these slides out, but the Q wave, if the Q wave gets really big, it'll stay with you for life. You'll never recover. This ST segment elevation, as you recover, it'll drop back down and be a little bit more normal. But if the interventricular septum is damaged, Q wave will always be huge. That's a sign that never comes back to normal. But yeah, there's ST segment elevation with a normal Q wave. So we know it's the interventricular septum is okay, not been affected. Here's a large Q wave in a patient. P wave, PR segment. Whoa, gigantic Q wave. Right. No, that can't be the R wave, because look how wide the segment would be then. It's like would be way too loud. That's all Q wave. And then yeah, the QRS complex would be okay then. But yeah, that's a person having a myocardial infarction. What do you do? What's the first thing you do? I always ask this question. Well, you give the patient an adult aspirin. 325 milligrams is a run-of-the-mill adult aspirin. And that interferes with the platelets' ability to clot, so that will stop the beaver dam from getting worse. And then you get them to the ER so they can do other things. So what are they going to do in the ER? They're going to take blood and they're going to look for certain cardiac proteins. When myocardial becomes ischemia and starts dying, they start leaking. And specifically, there's 3 of them you look for. Troponin, collectively. The question might just say troponin, but if it gets into the weeds, there's cardiac-specific troponin T, which is usually the first one to show up as high, and cardiac-specific troponin I. And then there's the MB fraction of creatine kinase. And both of these, the troponins, have very high sensitivity and specificity. If those are elevated in your blood, you had a heart attack. The CCK is a quicker test and a cheaper test to run. It has really good sensitivity. So if you're negative, if this is not elevated in your blood, you can wipe the sweat off your brow. You're probably not having a heart attack. But if it is elevated, it's not very good at saying that you have a heart attack, because it has low specificity. So it's good for ruling out, but not good for ruling in. Normally all troponins show up in the blood, or none. Normally none of the troponins should show up in the blood. They typically will rise about start. The TNT, as I call it, CTNT, will show up. That shows up about 3 hours after the heart attack has occurred. So that's the one you wait around in the emergency room 3-4 hours to see if that one raises. It peaks somewhere between 12 and 24 hours, and then it returns to normal 5 to 14 days later. TNL or TNI peaks in 24 hours, returns to normal 5 to 10 days. But elevation of any one of those things makes the diagnosis, but preferably one of the troponins. What's the treatment and the prognosis? Well, we've gotten really good at saving people's lives. Back in the 60s, if you had a heart attack, a third of the patients would die. That's down to 5% now. As long as they don't wait and they get into the hospital, into emergency room as quick as possible. Factors associated with a poor prognosis, advanced age, female, diabetes, prior myocardial infarction. 1 hour rule, that first hour after a heart attack is critical. About, if you're going to die, about 50% of the people who are going to die will die within that first hour. How about some therapeutic intervention? Well, it's incredibly painful, so they're on morphine. And then you have to try to bring the heart back by getting some blood in it. And to get blood in it, you have to open up the coronary arteries. So you'll be given like streptokinase as a fibrinolytic drug that will break down the clot and allow blood to flow. Aspirin, where we said there's an antiplatelet therapy. And then heparin will be started as an anticoagulation therapy to prevent new clots from forming. Okay, and if that doesn't work, which it usually doesn't, you can go to mechanical reperfusion. And balloon angioplasty is an older technique. It's been around forever. Some people still use it. But it's usually not the greatest when you're actually having the heart attack. It's usually more preventative. The new one now is aspiration angiojet, thrombectomy, and stenting. And you don't always use a stent. It's basically rotor-rooting. And you go in and you rotor-root out the atherosclerotic plaque and reopen the coronary artery. And I took all those slides out, but you can watch the video if you want at that link. Yeah, but that's it. You basically rotor-root that clot right out. And this has a suction, so it sucks the part of the clot into this tube. Because if you just rotor-root it and don't suck the clot in, you're going to be bombing downstream with all these embolisms. So, and there is a chance for a heart attack following that procedure. Whew, okay, I know that was a big lecture. See y'all later. One more lecture and we're done with this class for this quarter.